A Harvard research team just published a study in Science that is getting a lot of attention for the wrong reasons. Today, we are going to walk through what the study actually showed, what the most important finding was that almost nobody covered, and why both matter if you are thinking about where healthcare technology is going. Here's the setup. Researchers tested OpenAI's O1 reasoning model against attending physicians and residents on 76 cases from a Boston emergency department. Cases were structured to mirror the real ED workflow, starting with minimal triage information and building through labs, imaging reads, and a full workup. At each stage, both the model and the physicians were asked to produce a differential diagnosis. The headline number was that O1 hit around 67% accuracy at the triage stage. Physicians came in at roughly 50 to 55%. By the time full workup data was on the table, both groups converged in the 80% plus range. So the popular take was AI beat doctors at diagnosis. That take is not wrong exactly, but it is incomplete in ways that matter a lot. Point 1. The gap is biggest where information is sparsest. At triage, the cognitive task is generating a wide net of plausible diagnoses. That is exactly where humans underperform. There is a robust clinical literature on premature closure, the failure mode where a physician latches onto an early hypothesis and stops searching. Researchers estimate that roughly 12 million American adults experience some form of diagnostic error every year. The Boston study is a controlled demonstration of why that number exists. Doctors are not generating wide enough differentials at the front door, and a well-calibrated model appears to be better at that specific task. Point 2. The result is text in, text out. There is no imaging interpretation in this study. There is no real-time signal handling, no conversational diagnosis where the model has to decide what question to ask next. The inputs are text vignettes built from chart data. That is closer to a chart review exercise than to clinical care. Anyone citing this study as evidence that physicians are obsolete in any near-term sense has not read the methods section. Point 3, and this is the finding that almost nobody covered, the human plus AI condition did not outperform AI alone. Every health technology pitch deck for the past 3 years has assumed an additive model. Physician judgment plus machine breadth equals better outcomes than either alone. That is the entire premise of the co-pilot framing that dominates health AI marketing. The data from this study does not support that assumption. When physicians had access to the model's outputs, they did not pick up the additional accuracy the model would have delivered on its own. The likely mechanism is automation bias combined with anchoring. Physicians used the model's ranked list as a starting point, sometimes accepted incorrect rankings, and sometimes discounted correct AI suggestions that conflicted with their own prior. The net effect was roughly a wash. This same pattern has shown up in radiology research for nearly a decade. Radiologists with computer-aided detection assistance sometimes perform comparably to or marginally worse than those without it. The Boston ED result is the same shape of finding, just in cognitive diagnosis rather than image reading. It suggests that human in the loop is not automatically a quality multiplier, and may under certain configurations actually reduce quality relative to AI alone. So what does this mean? The article we are covering today makes the argument that differential diagnosis just stopped being a scarce cognitive asset, not in a speculative sense. The evidence chain from board exam performance 2 years ago to real case ED performance today is now long enough to treat that claim seriously. That has implications for clinical workflow design, for medical education, and for where value is actually going to be captured in healthcare technology over the next several years. We cover the setup and the core findings here in Part 1. In Part 2, the analysis turns to the triage inversion thesis, the liability bottleneck that almost nobody in the investment community is pricing in, and why the obvious AI diagnostics investment thesis may be the wrong layer entirely. Subscribe to On Healthcare for Part 2 and the full analysis. The link is below.